shoulder is the most mobile joint in the human body, while at the same time one of the most frequently injured. Those two facts are undoubtedly related. I often tell my physical therapy students that the shoulder joint alone will put one of their kids through college. Its fantastic range of motion is the result of our primate history. Before some of us took on habitual bipedalism, primate life evolved in the trees. This brachiating history spent swinging through the branches has left us with a shoulder with the greatest range of motion of all of our joints. Even the most trained gymnasts cannot do with their hip joints what they can do with their shoulders. The shoulder region is really a complex of joints. The sternoclavicular or SC joint, where the collarbone meets the manubrium of the sternum. The acromioclavicular, often called the AC joint, where the clavicle meets the scapula, and the true ball and socket joint between the humerus and the scapula. A group of articulations means not only more movement, but also more places where injury can occur. Consider this. A young woman on a local roller derby team is injured when she's driven into the rails. In the emergency department, part of her right shoulder droops down, but she also has an abnormal bony prominence sticking up from her shoulder, clinically called a step deformity. X-rays are negative, meaning her clavicle is not fractured, nor are other bones. So what's the diagnosis? To understand this clinical vignette, let's start by talking about the bones of the shoulder area. The two bones of the pectoral girdle are the clavicle and scapula. The clavicle is a relatively simple bone with a knobby medial end that you can feel at the top of your sternum. Then you can feel that it has a slight curvature anteriorly and then swoops back posteriorly, ending in a flatter lateral end. Now, this S shape of the clavicle gives it a bit more resiliency and strength, but it's still one of the most frequently fractured bones in the body. When it does break, the clavicle tends to fracture in its middle third. Often a broken collarbone results from a fall onto the shoulder, which compresses the clavicle medially against the sternum. One key reason for this vulnerability is that this joint, where the medial end of the clavicle articulates with the manubrium of the sternum, is the only place that the entire upper limb is jointed to the axial skeleton. Though there are 30 bones in the upper limb as well as 2 bones in the pectoral girdle, the only place that our entire upper limb has a bony joint with the axial skeleton is at the sternoclavicular joint. A fractured clavicle can't be casted. Now, there are braces to help immobilize the shoulder to facilitate healing, but in some cases it never does. A friend of mine who has done some acting has what's called a pseudoarthrosis, where her previously fractured clavicle didn't heal. Instead, it formed a false joint between the two broken ends. Now, the costume designers always had to dress her in such a way that when she moved, you couldn't see her two-part clavicle separate in its middle and poke out, which would make a weird lump at the base of her neck. In hindsight, she probably should have had surgery to put a plate on the broken clavicle to force it to mend properly. But in most people, a broken clavicle heals well on its own. The sternoclavicular joint contains a cartilaginous disc, which provides a bit of cushioning when a force is applied to the lateral shoulder. There are also several ligaments. An interclavicular ligament that bridges the two clavicles along the superior aspect of the sternum, as well as an anterior and posterior sternoclavicular ligament on the front and back aspects of the joint, respectively. There's also a costoclavicular ligament. This holds the clavicle to the first rib for added stability. The combined result of this anatomy is slight but multi-directional movements at the sternoclavicular joint. Next, let's look at the specific bony landmarks on the scapula to better understand the clavicle's relationship to it. I'm sure you've noticed that the scapula is a very movable bone. Kids can make their scapulae look like wings. It's a relatively freewheeling and quite mobile bone. But regardless of how it may look in an image or in a mounted skeleton in the lab, the scapula has no bony articulation with the vertebrae or the ribs. This is another reason the scapula is so mobile. There's many muscles that either insert or originate there, as we'll see after covering its anatomy. The scapula is a relatively thin bone, roughly triangular in shape. It has a superior border, a medial or vertebral border, and a lateral or axillary border. The triangle shape results in a superior, inferior, and lateral angle to the blade-like body of the scapula. The anterior surface is relatively flat and is called the subscapular fossa, since it's deep to the scapula facing the posterior rib cage. But there's an anterior projection at the superior end of the anterior scapula known as the coracoid process. Posteriorly, an easily felt landmark called the spine of the scapula expands laterally into the acromion process. Above the scapular spine is a depression called the supraspinous fossa, and inferior to the spine is a larger depression called the infraspinous fossa. Lateral to the scapular spine is the socket known as the glenoid cavity or glenoid fossa. You'll hear both used. A small bump above the glenoid cavity is the supraglenoid tubercle, and a small bump just below the socket is the infraglenoid tubercle. It's worth reminding you here that broad, flat surfaces can be the origin for muscles, and projections like tubercles and processes are often also muscle attachment sites. Now, it's the flatter lateral end of the clavicle, sometimes called its acromial end, that articulates with the scapula at the acromioclavicular joint. That's the shelf of bone we feel at the prominence of our shoulder. This is a synovial joint, but it's a simple gliding joint where the acromioclavicular ligament unites the two bones of the pectoral girdle. Other ligaments support the joint, including a coracoclavicular ligament and a coracoacromial ligament. The names of ligaments are generally really helpful. For instance, the coracoclavicular ligament unites the coracoid process of the scapula to the clavicle. The coracoacromial ligament, though, may seem puzzling, since it doesn't unite two different bones, but bridges two processes on the same bone. A ligament like this often serves as a tether of sorts to hold a muscle tendon in position, as this ligament does. It keeps the tendon of supraspinatus where it needs to be to do its job. The glenohumeral joint is where the real shoulder mobility happens. This is where the rounded head of the humerus articulates with the shallow glenoid cavity of the scapula. Remember that ball and socket joints are multi-axial joints at which flexion and extension occur, like when the humerus swings forward and back, where abduction and adduction occur, as when the humerus is drawn away from and then back toward the body, and finally where medial and lateral rotation occur, as when the head of the humerus is rolled inward or outward. The combination of all these movements in sequence is known as circumduction, like an arc. Circumduction only happens at ball and socket joints. The glenohumeral joint is surrounded by a joint capsule made of connective tissue. The capsule is loose inferiorly to facilitate full abduction of the upper limb, like as when pointing to the sky. Like other diarthrotic joints, this capsule is lined by a synovial membrane that secretes fluid to lubricate the joint. Another feature that promotes such a full range of shoulder motion is the shallow nature of the glenoid fossa. This relatively flat structure facilitates multi-directional movements of the humeral head. A structure called the glenoid labrum is a cartilaginous expansion that increases the surface area of the glenoid fossa, but really doesn't deepen it. There are several ligaments deep to the anterior portion of the capsule, a superior, middle, and inferior glenohumeral ligament, again named for the structures they connect and also their positions relative to each other. but the posterior aspect of the shoulder joint capsule is reinforced by 3 of the 4 rotator cuff muscles, while the 4th rotator cuff muscle helps the glenohumeral ligaments reinforce the anterior part of the shoulder joint. Now, all this contributes to some degree of stability while still allowing great mobility at the shoulder. The shoulder takes a beating during our lifetime, whether from playing tennis, pitching baseball, doing housework, being a house painter, or really any job that requires a lot of reaching. When I'm teaching gross anatomy to my physical therapy students, we typically have a dozen cadavers in our lab. Since the cadavers are generally older individuals, usually in only 1 or 2 of them do we find a couple of the glenohumeral ligaments, and almost never are all 3 of them still intact. The torn ligaments often just look like remnants or frayed shreds of connective tissue where those ligaments used to be. No wonder some older people may have trouble reaching things off a high shelf or pulling on their socks. Another relatively common shoulder pathology that I should mention is bursitis. That's an inflammation of 1 or more of the fluid-filled synovial sacs that surround many of our larger diarthrotic joints. If you remember, bursae are found around areas of friction around a joint and provide a thin, slippery membrane that allows moving parts, like tendons and ligaments, to more easily slide across each other or across a muscle or bone. There are several bursae around the shoulder joint, including the subacromial bursa between the acromion process of the scapula and the tendon of the supraspinatus muscle. That bursa often communicates with another bursa, the subdeltoid bursa, which is deep to the deltoid muscle. There's also a subscapularis bursa beneath the subscapularis muscle, and that is one of those synovial pockets that's continuous with the synovial membrane lining the shoulder joint itself. Inflamed bursae can swell and are painful enough to limit mobility. Rest and ice can help, as can steroid injections to calm inflammation. If swelling is significant, aspiration can be used to remove excess fluid. But shoulder bursitis can be a chronic condition once it sets in. With that said, my cautionary reminder still stands. All my patients are deceased. I'm not a clinician, but like you, I can look things up. In addition to the bones of the pectoral girdle, let's take a quick look at the proximal end of the humerus to understand some of the shoulder muscle attachments, specifically some insertions related to muscles of the shoulder. Remember that with regard to limb muscles, the origin is always proximal and the insertion is always distal. So some shoulder muscles that originate on the back, chest, or scapula insert on the proximal humerus. Adjacent to the head of the humerus, there's a greater tubercle that projects laterally and a lesser tubercle that projects anteriorly. Between them is the intertubercular groove. Makes sense since it's a groove between those tubercles. It's also known as the bicipital groove, since as we'll see, the tendon of the long head of the biceps brachii muscle passes through it. The humerus also has 2 necks of sorts. One is called the anatomical neck, which is the very slight constriction immediately adjacent to the head of the humerus, since a head is usually followed by a neck. But there's also what's called a surgical neck. It's the narrowed region distal to the tubercles where the shaft of the humerus forms. It's called the surgical neck because not only is it a common site of fracture in the humerus, but if a fracture occurs there, it usually requires surgical intervention, often with plates and screws to help it heal. This is because just distal to the surgical neck is the deltoid tuberosity, where the deltoid muscle inserts. So a fracture proximal to that area will cause the distal end of the broken shaft to be constantly pulled superiorly and displaced by the deltoid muscle. So with the bones of the shoulder covered, before we move on to muscles, let's return to our clinical correlation. Remember the young roller derby skater? And unless you think that's not a thing anymore, one of my former students who has her PhD and is now a fellow professor is a roller derby skater in her fun time. Anyway, the result of the skating injury was what's called a step deformity. Given the image of a step-down effect at the lateral end of her clavicle, but no broken bones, what do you think happened? Which shoulder joint was involved? If you said the acromioclavicular joint was injured, you're correct. This is known as a shoulder separation. The prominent sticking up is the lateral end of the clavicle, which has separated from the acromion of the scapula, so the rest of the shoulder area hangs down from its normal position. Most people recover from a shoulder separation injury in a few weeks to a few months, with the rest that's provided by a sling. But if the injury is severe, it could require surgery. In either case, physical therapy can be implemented to strengthen the muscles of the shoulder, scapula, and around the clavicle. Now, a shoulder dislocation is different. That's when the head of the humerus is displaced from the glenoid fossa of the scapula. That may require what's known as a closed reduction, in which the physician maneuvers the humerus back into the glenoid fossa, which I am sure is excruciating, but I've heard it lessens the pain as soon as it's over. And while shoulder dislocation takes longer to heal, it often heals on its own as well, with proper rest and physical therapy. The problem is either impairment to the shoulder can weaken it and allow for repeated bouts of the same injury, especially if not cared for or rehabilitated properly. Now, there are so many muscles that govern shoulder movements that I like to group them. In my thinking, this really helps us understand the muscles' origins and insertions, which in turn relate to their movements. For example, some shoulder muscles move the scapula or the clavicle or both. Many of these can also serve as fixators that anchor the scapula in place against the chest wall, so that muscles that originate on the scapula can move the humerus. So let's look at these shoulder muscles in groups, and I'll remind you of their nerve supply. This will tie back to our coverage of the brachial plexus, as well as cover their actions on the joints of the upper limb. Remember, not only does the insertion of a muscle tell us what bone the muscle acts on, but the side of the joint that a muscle crosses tells us a lot about its action at that joint. First, let's cover a group of 7 muscles that attach some part of the axial skeleton to the shoulder girdle. And all of these are review muscles, since they are either superficial appendicular muscles we talked about with the back, or chest muscles we touched on with the layering of the thorax. These are the trapezius, levator scapulae, rhomboid major, rhomboid minor, serratus anterior, pectoralis minor, and subclavius. What links these together is that they originate on the axial skeleton, which here includes the skull, ribs, or vertebrae, and that they insert on the clavicle, scapula, or both. Trapezius originates from the skull and the spinous processes of cervical and thoracic vertebrae, and it inserts on the lateral third of the clavicle, the acromion process of the scapula, and along the scapular spine. The upper fibers of trapezius elevate the pectoral girdle, the middle fibers retract or adduct the scapula, and the lower fibers depress the pectoral girdle. Do you remember what was so unusual about the trapezius muscle's innervation? Yes, it's supplied by a cranial nerve 11, the spinal accessory nerve. We've also talked about levator scapulae. It takes origin off the transverse processes of C1 to C4 and inserts on the medial or vertebral border of the scapula above the scapular spine. As a result, levator scapulae elevates the scapula and can rotate it in such a way as to point the glenoid cavity inferiorly. But if other muscles hold the scapula in place, levator scapulae can also flex the neck laterally. It is supplied by the dorsal scapular nerve off the roots of the brachial plexus. Levator scapulae shares that nerve with rhomboid major and rhomboid minor, which both originate off spinous processes. Rhomboid minor typically takes origin from the spinous processes of C7 and T1, and inferior to that, rhomboid major originates usually from the spinous processes of the 2nd through 5th thoracic vertebrae. Both muscles insert on the medial or vertebral border of the scapula. Rhomboid minor near the base of the scapular spine, and rhomboid major inserts inferior to the spine of the scapula. Both muscles can act to elevate the scapula as well as retract or adduct it, fixing it to the thorax. And like levator scapulae, their oblique angle helps them rotate the scapula to point the glenoid cavity inferiorly. Serratus anterior is one of my favorite muscles for a couple of reasons. One is its interesting origin, like a series of fingers of muscle taking origin off the anterolateral ribs. It sneaks around deep to the scapula and attaches to its medial or vertebral border, but on the anterior side of the bone, meaning the side of the scapula that faces the ribs. Serratus anterior is also interesting for its actions. It can protract the scapula, bringing it forward, but it also helps fix the scapula against the rib cage, holding it so that other muscles that originate on the scapula can do their job. Serratus anterior also allows abduction of the upper limb above the horizontal plane. Without serratus anterior to rotate the scapula so that the glenoid fossa faces upward, we wouldn't be able to clear the shelf of bone at the acromioclavicular joint for the full range of abduction at the shoulder. Also, serratus anterior is the only muscle supplied by the long thoracic nerve off the roots of the brachial plexus, and unlike nearly all other muscles that are innervated on their deep side, this long thoracic nerve enters serratus anterior's superficial side, and this makes it more prone to injury than deeper nerves. For example, if someone gets knifed under the armpit in a bar fight, the long thoracic nerve can be cut. One sign of injury to this long thoracic nerve is that the person cannot raise their arm above horizontal because their serratus anterior can't rotate the scapula in order to do so. Also, if you ask the person to lean against a wall, like doing a push-up off the wall, the scapula on the affected side will wing out posteriorly. This is because serratus anterior is no longer holding the scapula against the rib cage. These are among the interesting tricks that clinicians use to test the functions of muscles. Another muscle that takes origin off the ribs and attaches to the scapula is pectoralis minor. It originates off typically 3 of the upper ribs, ribs 2 to 4 or 3 to 5, and it helps stabilize the scapula in place, but can also help depress it. And when the scapula is fixed, in other words, held in place by other muscles, pectoralis minor can assist in raising the ribs. Do you remember the medial pectoral nerve off the medial cord of the brachial plexus? That nerve supplies pectoralis minor. And our last in the group of muscles that originate on the axial skeleton and insert on the pectoral girdle is subclavius. It originates on the first rib and inserts on the inferior aspect of the clavicle. And it helps stabilize the clavicle during movements of the shoulder girdle and can also slightly depress the clavicle. It's supplied by the so-called nerve to the subclavius off the upper trunk of the brachial plexus. The anatomists were being very literal that day. Don't we wish they named all nerves like that? 2 muscles of the shoulder originate all or in part from the axial skeleton, but attach to the humerus. These are pectoralis major and latissimus dorsi, both mentioned in earlier lessons. Pectoralis major has a clavicular head that originates from the medial half of the clavicle, and its sternal head takes origin from the sternum and upper 6 costal cartilages. Latissimus dorsi originates from the spinous processes of the lower 6 thoracic vertebrae and 5 lumbar vertebrae, as well as the pelvis, lower ribs, and the thoracolumbar fascia. Now, at first glance, you wouldn't think these muscles have much in common, but because of their insertions, these two muscles share 2 of their 3 functions. Pectoralis major and latissimus dorsi both insert on the intertubercular or bicipital groove on the humerus. So because they both cross the axilla, they adduct the humerus, and since they both attach anteriorly to the proximal humerus, they both medially rotate the humerus. But because it's on the anterior side of the body, pectoralis major can aid in flexion of the shoulder, while latissimus dorsi, located posteriorly, extends the humerus. Latissimus dorsi is supplied by the thoracodorsal nerve off the posterior cord, while pectoralis major is supplied by both the medial and lateral pectoral nerves. Next, let's consider a group of 9 muscles that connect the shoulder girdle to the humerus, or the radius or ulna. First, I'll just mention biceps brachii and triceps brachii because each of these 2 multi-headed muscles has 1 or 2 heads that cross the shoulder joint. But since their main actions are at the elbow, I'd like to cover them in our next lesson. That leaves then the 3 non-rotator cuff muscles, deltoid, coracobrachialis, and teres major, plus the 4 muscles of the rotator cuff as the remaining muscles that act at the shoulder. The deltoid muscle makes up the rounded prominence at the shoulder. It has the same origin as trapezius, along the lateral clavicle, the acromion process, and the spine of the scapula. It inserts on the deltoid tuberosity of the humerus and is one of 2 muscles supplied by the axillary nerve. That's one of the 5 terminal branches of the brachial plexus. The anterior fibers of the deltoid aid flexion and medial rotation of the shoulder. The posterior fibers aid extension and lateral rotation of the shoulder, but the lateral fibers abduct the humerus to horizontal. And then beyond that, serratus anterior has to rotate the scapula if we reach any higher. Coracobrachialis is a small muscle that originates, you guessed it, on the coracoid process of the scapula. It inserts on the proximal humerus. The coracobrachialis is a weak muscle that contributes to shoulder adduction, and some sources indicate weak flexion as well. Like the other muscles of the anterior arm that we'll meet in the next unit, coracobrachialis is supplied by the musculocutaneous nerve, another of the 5 terminal branches of the brachial plexus. Teres major originates on the inferior aspect of the axillary or lateral border of the posterior scapula, and it inserts on the intertubercular groove of the humerus. In fact, a fun saying about these related insertions is the lady between 2 majors. The lady is latissimus dorsi, and the 2 majors on either side are teres major and pectoralis major. Teres major has the same functions as latissimus dorsi. It extends, adducts, and medially rotates the arm, but it's supplied by the lower subscapular nerve off the posterior cord of the brachial plexus. Last but not least is the group of shoulder muscles most of you have likely heard of, the rotator cuff. And that's cuff, not cup, as some people may think. This is a series of 4 muscles, supraspinatus, infraspinatus, teres minor, and subscapularis, that all connect the scapula to the humerus, forming a cuff of muscles around the head of the humerus. Interestingly, though, despite their group name, not all of them rotate. Supraspinatus conveniently originates in the supraspinous fossa and inserts on the greater tubercle of the humerus, but it abducts as its superior position at the shoulder suggests. In fact, it performs about the first 10% of abduction, Then the lateral fibers of deltoid kick in to take the humerus to horizontal, followed by serratus anterior rotating the scapula. That's a great example of how muscles work in a series toward a single action like full abduction at the shoulder. Infraspinatus originates in the infraspinous fossa, also convenient, and like supraspinatus attaches to the greater tubercle, but more posteriorly, so it laterally rotates the arm. Both the supraspinatus and infraspinatus are supplied by the suprascapular nerve off the upper trunk of the brachial plexus. teres minor is the third rotator cuff muscle. It originates on the scapula just lateral to the infraspinatus and inserts just inferior to it on the posterior humerus, so it laterally rotates the shoulder as well. It's the only other muscle besides the deltoid supplied by the axillary nerve of the brachial plexus. And finally, the fourth rotator cuff muscle is subscapularis. As its name suggests, it originates on the subscapular fossa, which is on the anterior surface of the scapula, and it inserts on the lesser tubercle on the anterior humerus. For this reason, it medially rotates the arm at the shoulder. Both the upper and lower subscapular nerves off the posterior cord supply subscapularis. But beyond any rotation, the rotator cuff muscles share the important function of stabilizing the capsule of the shoulder joint from nearly all directions. Supraspinatus superiorly, infraspinatus and teres minor posteriorly, and subscapularis anteriorly. Sometimes the mnemonic SITS, S-I-T-S, is used for the four muscles that sit around the shoulder joint and stabilize the head of the humerus in the glenoid fossa. And as I emphasized at the start of this lesson, the shoulder joint can use all the help it can get with stability.